2, 1, go. So welcome to this ESSO webinar on the first of a series that's called the Current Controversies in Colorectal Cancer. We're joining you live from the conference here in Gothenburg, and I'm delighted to say we have a stellar panel of presenters here who are going to be going through some complex scenarios in patients with colorectal cancer this morning. So my name is Henry Smith. I'm a colorectal fellow from Copenhagen and a member of the colorectal ETC here at ESSO. And I'd just like to invite my panel members to introduce themselves one by one.
Hello everyone, I'm Ilaria Govoni. I'm a surgical resident. I'm from Padova, Italy.
Hi everyone, I'm Regina Bitstan. I'm a radiologist from the Netherlands Cancer Institute.
Hello, I'm Gerard Beets. I'm a colorectal surgical oncologist in Maastricht, the Netherlands.
And I'm Mats Perman, a clinical oncologist from here actually, so I was quite cheap to contract. They didn't have to fly me in.
Perfect. So we'll get going now then. So we just say that none of us have any conflicts of interest that are relevant to declare at this moment. And so the idea with these webinars is that we will have a series of other webinars coming soon within the next 6 months that will be available on the ESSO platform. And we just wanted to give a taster of what those webinars will be based on. And here we really want to set a focus on the current issues that are becoming increasingly complex in the management of patients with colorectal cancer. So we'll be focusing on 3 themes today: the management of patients who present acutely, and what challenges that can present. The treatment of patients with early colorectal cancer, which is becoming an increasing proportion of patients these days. And then finally, what to do in patients who respond maybe too well to neoadjuvant treatments, and how we should react to planning their treatment. And so Ilaria is going to talk us through some cases, and so we'll start with the first.
Yeah, we can start with the first cases. It's a female, 72 years old, with some comorbidities, such as right breast cancer in the past and some cardiac comorbidity. She's on cardioaspirin. Since February, she complained about urinary tract infection recurrence with some pelvic pain, dysuria, and she supposed that these symptoms were correlated with her uterovaginal prolapse. So she went to gynecologist, to urologist, but all her evaluations were inconclusive. And she presented herself in July in the emergency room with fever, pelvic pain, constipation, weight loss, and the blood test revealed very high inflammatory markers, and she was admitted to the urology unit. And at this point, the first CT of the abdomen were performed. So I invite Regina to...
Yeah. Indeed, Houston, we have a problem. We do have a problem. So you see this already in one glance, that it looks completely inflammatory. What you can see here on the bowel, if you look at the sigmoid, I cannot point it, but maybe the next is, no, the better, yeah, that one. You can see that on, first of all, you see this, the massive blowout of the colon, and that is because of a very large tumor, which is down the descendants and sigmoid. You can see some masses there in the left pelvic, which is on CT always very difficult, of course, where does normal organ start and where it is really the mass. But it looks like in the left adnex region. I also can see some fluid, air in the bladder. So there must be something like a fistula there. So yeah, that's what you can see on this CT.
Yeah, thank you very much. So far, the patient seemed to have sigmoid colon carcinoma complicated. And yeah, the sigmoid was not performed because inadequate preparation of the patient. So I think we can start to discuss what we can do.
Yeah, so this is a very complex situation. So normally when we have an MDT discussion, we've got time to plan and sit and think. And so I have a patient who's come in very acutely with a very complex tumor.
Yeah, if she comes in on Friday, you don't have the time for an MDT meeting.
No.
Yeah.
So what are the things that you're thinking about, Gerard, with this patient in terms of how they should be treated and what steps should be taken first with them?
So in a patient who's acutely ill, you first treat the acute part of the disease, like give her fluids and antibiotics. If she is septic, more antibiotics. And if the obstruction is a problem, which it is, then you have to relieve the obstruction first, not jump into it and do a resection if you don't know what it is. And you could think of asking the endoscopist to put a stent in there, but on the CT scan it looked like a very long, narrowed sigmoid. So probably we would give this patient a transverse colostomy to relieve the obstruction, to make her better again, to let her get well, and then perform further investigations. You can do an endoscopy from above or below. What is it? Maybe you need an MRI to more exactly say where it is. But we would start with resuscitation, antibiotics, and a colostomy.
So taking something from an acute situation to something that is at
yes.
least partly planned.
Yeah, if it's diverticulitis or something, you can go on with treating the acute, but if you think it's cancer, turn it into a more elective where you have time to make the proper decisions. Because if you try to take it out and you have positive margins on the left pelvic sidewall, then you've actually hurt the patient maybe more than you've helped her.
So what was it that was the first strategy then?
Yeah, what they decide is, they agree with you. So what the plan was to perform a diverting stoma, so they did, and do a completion colonoscopy with biopsy, and to give her some neoadjuvant therapy and then the surgical resection. But they did the sigmoid and was the adenocarcinoma, but something went wrong. So he was discharged without antibiotics, but some day later she presents herself again to the emergency department with fever, abdominal pain. The blood test showed a rising inflammatory level, and was admitted to the oncology unit. And again, the CT was performed.
But can I first ask the oncologist here about the idea of this MDT to start with neoadjuvant chemotherapy?
Yes. When I was a young oncologist, I thought chemotherapy and radiotherapy had a cleansing effect in general. So I'd like to know, were there an oncologist present at this MDT?
For sure.
Probably a young one. Because this lady, she's not on the strong side from the beginning. So we must look at the tumor situation and the patient situation. So she's not a stellar candidate for any oncological therapy. It's a colon cancer, so radiotherapy, even if it's deep down in the pelvic region, we know that colon cancer is not as sensitive to radiotherapy as rectal cancer. So we have chemotherapy. The lady has a history of some cardiac problems. She is in a cachectic state, so we don't have the margins to administer effective therapy. But that's not the main cause for my hesitation. With experience, I've got to appreciate that septic, this kind of acute septic thing is quite traumatic for the patient. Surgery is nothing compared to be admitted to the emergency room after 2-3 days of fever and going into septic shock. And if you start chemotherapy, this is a trial and error approach. We don't know which way this will end. It might as well be pouring gasoline to the flames.
So there would be a discussion in the MDT, the surgeon saying, I really would like you to make it smaller so I can have a better chance at clear margins. And you would say, yeah, but I'm not sure
Number
if that's
one,
gonna work.
number one, I will not be able to administer high or effective doses of chemo in this patient. Number two, the tumor situation brings quite a big peril of a new septic event, which is also very traumatic for, from the patient's perspective. So I've grown more reluctant to take these patients into a neoadjuvant approach, because not even it can go either way, but the wrong way is quite traumatic for the patient.
Okay.
So we're in a situation here as well where we talk often about having infection control before you start with neoadjuvant treatments, and you have a patient who's now defunctioned. Where would you set a boundary there? Would you have to wait 2 weeks, 3 weeks without them having fever, with having normalized inflammatory markers before you'd start giving them systemic therapy? Or is there anything that you consider, Mads, with that in terms of what is control?
Yeah.
How long do you need to have control for?
And that's the third problem, because the oncologist will tend to wait for something, and then we get mixed up because we are talking about the infection, but during which the tumor keeps growing. So if I would have been present at this first MDT, I would have been maybe not 100% opponent to this approach, but I would have raised some caveats.
Okay. So the CT, well, obviously what is remarkable is that the dilated colon, the blowout, is all gone. So something
So
must
this is
have
2 weeks,
changed.
2 weeks later or so?
Yeah.
At the emergency,
almost,
yeah, okay, immediately thereafter. But you can also see this inflammation in the pelvic as all dirty fat. Let me scroll further. So now you can see the problem, despite the artifact, beam hardening artifact of the hip prosthesis. You can see that there is definitely a sort of a mass with a necrotic center, looking like an abscess, perforation, something like that, and also some thickened small bowel loops, thickened wall. So it's all like one massive cake of inflammation in there. Yeah.
Yeah, thank you very much. So she started the antibiotics, but unfortunately after 48 hours of antibiotics, she still have fever, pain, and the inflammatory marker were rising. So yeah, what they decide is perform a surgery. So
Yeah, so you were right in being a little cautious.
This time I was right.
Yeah. So ideally we wanted this patient to get better, so we would be able to prehabilitate her to get her really well, and that would be the ideal picture, and then give chemotherapy and then surgery. But this is not gonna work. So our oncologists were very much in line now with, no, we're not gonna give this patient chemotherapy. You have to fix this first. And we considered putting a drain in the small abscess, but we thought this patient is ill from the tumor itself. So we again looked at the CT scan and said, well, it's a lot of infiltration around it. It's not invading the pelvic sidewall, it's invading the bladder. But we still, and in a patient who's not very well, this is going to be a big operation, but if we're going to take the tumor out, then we need to take it out in an oncological way. So we decided, well, and she agreed to that. Of course, we said to her, we're going to have to remove the bladder, potentially the uterus, the next part of the bowel. I'm not sure if we can make a stoma, but she agreed. She was not feeling well. She said, take it out.
yeah, so they perform a surgery and block resection with sigmoid colon, part of the bladder, left adenexa, two small bowel segments, and part also of the anterior vaginal wall. And the histology were not was good. I mean, final pathology stage were PT4B and 0, and with margin free of tumor. So, and she's waiting for oncology evaluation.
Yeah, so this is where the surgeon, you've done a big resection, you're not sure if the margins are okay, so you're a little anxious to wait for the pathology result. But then this was good. So her risk factors for having metastatic disease is basically T4 and a perforated tumor. So instead of being a high risk, she's not a low risk. So she has to recover from this. What is her benefit from adjuvant chemo?
Well, that's always a group level question. So in her individual case, her whole history will weigh in. She has had something swollen, something active, but we're so happy that we had a radical resection. So I will take it from the scenario which you first said. If we did something that first night, we would end up with an R1 or R2, and now it's R0. That's the big difference. Adjuvant therapy or not, probably everyone would offer her adjuvant therapy, but speaking of an effect there, is modest. So always think about the importance of the surgeon, the importance of the radiologist, and the non-importance of the oncologist in making the big difference. I will raise one question. If you refer any patient, potentially curable, into neoadjuvant therapy in this complicated setting, make sure you have a continuous dialogue. Make sure you work in close proximity to your oncology department. Because there's always a peril that the patient is sent to an oncology department where a young resident gets this mission. Give this lady 3-month neoadjuvant therapy and then get lost in the complications. But you always have to interrupt immediately if the chance of a radical resection is getting lost in oncological complications. So,
yes, I like you saying that, because when we say please give chemotherapy, that doesn't mean it has to go in if the patient gets unwell. Yeah, I've seen that happen too. Yeah.
Surgeons and radiologists save lives. If we don't know where the tumor is, the patient will die. If we don't take it out, the patient will die. Oncologists, small margin effects, this is a very important case. The oncologist always has to be prepared to back away from the patient, not to compromise the surgical outcome.
So, but if this patient would say, I have so much to live for, if I can gain 3-4%, I want to go for it?
Yes, on a group level, but on your individual level, you have this and this and this. You've been in a cachectic state for so long.
Yeah.
What about rehabilitation?
Yeah.
What about the new results of physical exercise that have quite a large effect, comparable to adjuvant chemo? So this kind of patient, probably if we send her to adjuvant therapy, we will interrupt her natural rehabilitation after a long period of cachectic state. So group level, it's okay, but
so maybe she benefits more from getting rid of her stoma and getting on with her life.
Physical activity,
yeah. Okay.
That kind of stuff.
So there's plenty to discuss, and we can see that there's no easy answer to a lot of these situations, and so we'll be taking more of these cases on our webinar that will be coming up within the next 6 months with acute presentations in colon cancer. And so now we'll move on to our next theme, and so that'll be patients with early colorectal cancer.
Yeah, the next patient is a male, 71 years old, with some mild comorbidity again, like diabetes or pulmonary disease. And after a positive screening test, he performed a colonoscopy that showed presumed benign sessile polyp, 1.5 centimeter in the descending colon, and it was removed by endoscopic mucosal resection. The pathology examination show well differentiated adenocarcinoma with this characteristic, MMRI proficient, intermediate grade tumor budding, less than 1 millimeter margin, and level 1 submucosal invasion, and no lymphovascular invasion. And the staging didn't show any evidence of metastasis. Yeah.
So this is becoming an increasingly common scenario that presents to MDTs across the world. Now we've got someone who presumably had a benign polyp, and it turns out that they have an early cancer. And then the question is always, is there need to do anything else, and what should be done if something is to be done in these patients? And so what are the factors that you consider in your MDTs when you're presented with patients like this?
Well, there's also a reasonable chance that this patient will no longer be discussed at the MDT because we've moved from, like 15 years ago, this would be a 10-second discussion in the MDT, and as a reflex we would take out the colon because it was cancer and it could be in the lymph nodes. Now we know we have done hundreds and thousands of colon resections without benefit. So the risk for lymph node metastasis in this kind of situation would be less than 5%. You would still discuss this with the patient, but we would favor leaving this patient alone and following up.
I think it's very impressive. I think the Dutch are very much leaders in this field, because a lot of other places there's still a lot of discussion backwards and forwards about what risk is too much and what do we think about that as surgeons. And I think there's the new Dutch guidelines that are very more proactive in avoiding surgery in these patients, but there's still a lot of international guidelines where that would be a 10-second decision. That there's a risk factor, there's a potentially residual tumor that's in place where the polyp was, and so be many people who would say, according to the book, that should be a larger operation. But then, as Gareth says, we know the majority of patients who would be operated on in that circumstance will not have any residual disease. So that's the interesting question about both whether there is disease within the lymph nodes, but also whether there's disease within the lumen of the bowel. And I think we are moving more and more. I think the rest of the world, we're catching up, moving more and more to a more reserved approach to operating on these patients.
I mean, there's other factors too. You have to discuss this with the patient. If you have a high surgical risk, you're going to veer more to that side. And the thing is, it's different in rectal cancer. We do have MRI follow-up for the lymph nodes, and colon cancer. As yet, we don't have a good follow-up to save the couple of percentages, maybe ctDNA or something in the future. But
how would they be followed up, Gerard, in the Dutch system? So now if they had an early cancer with low risk factors that they weren't operated on, how often would they be invited back? Would they be brought back to regular endoscopic controls, or would they?
If it's a very low risk factor, they stay with the gastroenterologist and maybe once a CT scan, but for the rest it would just be endoscopic follow-up.
And so as Gareth says, there's a lot of different factors that should be discussed in this, both in terms of what the patient can tolerate in terms of treatments and complications with further surgery, what effect the location of that tumour has, so right side versus left side of the colon, in terms of what functional consequences might be in terms of performing more surgery. And there's also that recognition that maybe those risk factors aren't the same as each other. There's some risk factors that are worse than others, but also maybe we need better risk factors than the risk factors that we use today. And there'll be some of the things we'll be coming into in that webinar that will be coming shortly. So now we move on to something that's the same but slightly different.
Yeah, the next patient is a female, 80 years old, and she presented herself with rectal bleeding. So she performed a colonoscopy that showed from 2 centimeters from the anal verge, a 3 centimeter of tumor, and the transrectal ultrasound didn't show any suspicion for invasion of muscular. Yeah, so it was staged as T1. MDT decision proposed transanal endoscopic microsurgery, and so was performed. And the pathology examination showed a moderately differentiated adenocarcinoma with this characteristic lymphovascular invasion, level 3 of submucosal invasion, microradically completed margin, and MMRI proficient. So, and there were no suspicion for metastasis. And
Yeah. So was the tumor on the anterior side? you
yeah.
remember?
Oh,
Yeah.
yeah.
Yeah,
Yeah.
because I can see that on the MR, right? The spot where they did the excision, you can see like a hole in the wall on the anterior side. So, yeah, that's, and the mesorectal fat is clean except for this big node, which is very surprising for something, for tumor in that stage. Very big node, so.
Are you sure it's a node? I think isn't.
Or is it the bowel
The
that is
sigmoid that
going
goes back.
into?
In the, yeah.
So I need
the report
another,
of the-
yeah, I need another slide.
Yeah, sure, it's very hard.
Yeah.
This, yeah. No,
They didn't, they didn't.
Yeah, but this was a bubble.
It
Yeah,
looks like,
when you scroll
yeah,
through it.
yeah,
Yeah.
you have to scroll through it. Yeah.
Yeah, but this takes a little more discussion in the MDT than the previous one, because the risk factors are lymphovascular invasion, SM3, around 15% chance of having lymph nodes involved. We don't know if that goes down if you don't see anything with MRI. Maybe the chances are less, but this is something that requires a discussion, and in some parts of the world they would still do a resection because of that. I think that would be the standard for a patient with not a high surgical risk factor. Go on.
But I think the interesting thing is, so now with rectum as well, so there's more possibilities than we have with patients who have colon cancer. So we've got better radiology, so we can see, and we can be more certain when we follow those patients if there's any development. But then we also have our oncology colleagues who have other potential treatments that could be given. So then it's not just a treatment between surgery or surveillance, but then there's also the potential for adjuvant therapy in that setting. And
yeah, so I would say the higher this is, the better, or the more I would favor doing a high TME resection. The lower it is, if you do a TME resection, the more functional problems the patient can end up with, or if it's very low, even with a coloanal anastomosis or a stoma, or even if you think you can make an anastomosis and it breaks down, the patient ends up with a stoma for a very small tumor. So when I discuss this with patients, they sometimes say, 15%, doctor, that means 85% there's nothing there. Yes, true. And we have with MRI, we can survey them, so that is something that we offer them, but people have also considered, we know chemoradiation, the smaller the tumor is, the better it works. So if there is something in the lymph nodes, you might be able to sterilize it, but we don't know.
Where is the cancer? Please tell me.
Yeah.
If I should direct such a potential intervention, it's like a scalpel. Only that the patient start hurting 5, 10, 15 years after radiotherapy with the scalpel. Where should I cut?
Yeah.
Where is the cancer? How can I weigh the potential harm induced by my therapy against the gain. How should I think about volume, irradiated volume?
Yeah.
So there will always be a reluctancy among oncologists to kind of radiate blindly.
Yeah.
And that's the problem with this case. Maybe not logical, because if you had come and said, this patient has some strange condition, so we cannot even perform a local excision, please do something, then we would gladly give chemorad with a high potential of.
So, but what if you say, okay, and so we agree we're going to watch this, but then 6 months later you see 2 nodes appearing. You could say, I'm going to take it out, but in a very low tumor, that would mean an APR with a stoma. The patient looks at you and says, can you try to avoid giving me a stoma?
But then there's a problem. The patient has shown itself to be among the 15%.
Yeah.
And what is 15%? Is it just mathematics? No, it's biology. And oncologic therapy has success with the good biology. I mean, it's also a predictor of the future if a tumor shrinks. It's a prognostic as well as predictive. But so I start to get worried that this patient now has lymph nodes. So the patient and the tumor has shown itself to be biologically challenging. And then again, what is guaranteed to take the tumor out? It's surgery. And right or wrong, I personally always will be more nervous speaking of pelvic failure than the other tumor. We had a colon tumor, and we have a small risk that the patient will develop cancer and spread. But the risk of not having local control in the pelvis, not considering anything else, it's a scenario that I don't like to risk. So for me, playing with chances and risks in the lower pelvis is with higher stakes, speaking about suffering for those that we fail. So this is not a black or white. But
if we go back to not having the patient having declared itself to be unfavorable biologically, but going back, this looks like an okay tumor, so the worry may not be as much survival, because we can cure this patient with a very early tumor. It's trying to avoid the damage as much as possible. If we do nothing and it works out well, then yes, that's a clear winner. But the other 2 therapies might be overkill. Now we do in the Netherlands have the TESAR trial running, comparing those 3. And so the difference will be not oncologically, but will be functional. What is better and what is not. So yeah, we hope that trial doesn't take too long, because we are seeing these patients quite regularly.
Yeah. And I think there's also the other interesting thing in this scenario. So if that differentiation between T1 and T2 cancers is quite difficult, and if you suddenly have a T2 cancer, watchful waiting after definitive radiotherapy becomes an option. And that's where that discussion about risk factors is now irrelevant, because if the tumor's gone, we don't know which characteristics it had in the first place. And I think it feeds into the same discussion of trying to identify which patients are the bad actors from the start and who needs more definitive treatment than otherwise.
Yeah. So the tumor doesn't have a sort of a biological. So we're still looking at anatomy, and while it's really about the biology.
Speaking of a beneficent effect of intentional organ-sparing treatments, is that we have started to adapt the radiotherapy volume, like in studies like the Star Trek study. So we've managed to, when you have the intention from the beginning, we are starting to put the balance of harm inflicted by radiotherapy, potential harm. It's much more with a reflective approach, with much more chance that we can use radiotherapy without harming the patient in a significant way. So it's always better to go for an intentional, from the beginning approach than to end up in a scenario where, could you fix this? Because we have this situation. And going back to the early colon cancer case, which we will have more and more, we oncologists all over the world, we can take care of your patients for one day. If you just get together and get an approach where you can clear these cases off the MDT, because it's so boring. We just sit there and wait for your discussion to end. So it would be lovely if you just get a common approach.
Okay, we'll do that.
I think that leads us nicely on to the final case, and that's what we're talking about, responses to neoadjuvant therapy. So, Lara, if you would like to introduce the...
Yeah, the next patient is a 56-year-old male with no comorbidity, and he presents in November with rectal bleeding, increased bowel frequency, abdominal bloating, and urgency. And no weight loss, no fatigue, no diarrhea, no constipation. And the digital rectal examination show a mass palpable at 7 centimeters from the anal verge. So a colonoscopy was performed and show in the rectum a 6 centimeter lesion. And the histology revealed an adenocarcinoma moderately differentiated MRI proficient. So the CT didn't show any distant metastasis, and this is the pelvic MRI. So I invite you again.
So the pelvic MRI shows really the mass as you saw on the endoscopy, but especially on the anterior side you see the breaching of the tumor through the wall, but not really extending into the mesorectal fascia. So that's free. So I would say it's a T3, 5 millimeter extension outside the bowel wall, something like that, T3B. It's also very low because there is an image of the pelvic floor made in a coronal plane, as we say that. So that's one thing that is obviously also high risk, also for the pelvic floor.
There's also some EMVI.
And EMVI and nodes that I can see. So a lot of high risk features, I would say. A very high risk tumor.
Thank you very much. Yeah, they agree with you. The stage has a CT3B and 2 MV positive, and the fascia was free. So
that would be the discussion point now. So in this patient, what would be the indications for neoadjuvant therapy? What type of neoadjuvant therapy should they be given, and what's the intention with that? Should it be with the intention that we get so good a response that we can spare an organ, or that we're planning to make control after surgery a more secure situation? What are things?
I think we would most of us would agree that locally advanced is a very broad terminology that's not well defined, but this would fit locally advanced. If it was MRF positive, it would be even more locally advanced. But if you do surgery on this patient without neoadjuvant therapy, you have maybe a risk for local recurrence of 20% or so, which is way too high, because that can give patients really trouble. And we were giving these patients chemoradiation, but now we will spend in the MDT some time discussing what you're going to discuss now.
So what are the options, Mads, in terms of the treatment this patient could have, and how do you go about picking the regime that they should have?
I personally try to look at the two different aspects: local risk and distant risk. Yeah. And here we have a tumor that carries both. And what worries me is the EMVI, always. Nodes is an indication, but not always. But EMVI is always a troubling sign. So with the TNT trials we have had, there are some controversies, but what is proven is that you lower the risk of metastatic spread the first 3, 4, 5 years. And this here you have, I would be more worried about the risk of metastatic spread in this case, and as a byproduct of starting or completing TNT, we would have a local effect, which is beneficent for the surgeons. But for me, here the priority is to start systemic therapy. And I happen to live in the country which, together with the Dutch, performed the Rapido study. So my national guidelines say I should apply the Rapido concept. But if we get above our national borders, I would really try and lift up the Prodigy results. Now, again, Prodigy didn't include so many local ugly cases as Rapido, but it has a unique feature, and it introduces a triplet chemotherapy, and it has shown survival advantage as well as disease-free. So, internationally speaking, I would go for TNT, and I personally would adopt the Prodigy concept with FOLFIRINOX, but I'm in Sweden, so I'm bound to use an adapted Rapido approach, where actually we use a shortened chemotherapy period. We've cut it down from 4.5 months to 3 months.
Okay.
So if the patient was fit and healthy and can tolerate, because the Prodigy is a little more intensive schedule than the Rapido, or is it the same? Or
now I'm going to tell you an oncological secret. If you have 3 active substances, you have a much broader possibility to adapt the treatment to the patient. You can lower one and then keep the intensity. So the defense of the Rapido, that you only have 2 different chemotherapy, is actually not a good argument, because when you have 3, you always have to adopt the doses and to the individual patients, and they have different. If you have diabetes, for example, neuropathy is coming more quickly, and then if you have 3 stuffs in your regimen, then you can kind of have a greater liberty. So I'm a Prodigy fan. I'm sorry. So I will be kicked out of my national.
So you're saying, well, we think 3 things is worse than 2 things,
and I say 3 things is better, because then your cocktail.
Yeah, you can play more with it. Okay.
If you're a bartender, it's more easy. It's more easy with 3 ingredients than with 2. If the guest happens not to like one of your ingredients. I just say that's my.
Okay.
Yeah.
What did we do, Prodigy?
Oh no, they decided to perform a long course chemoradiation, chemoradiotherapy. Oh,
This was 2021.
Before
the
time.
TNT results.
and the restaging show actually a complete response because the digital rectal examination didn't show any mass. The sigmoidoscopy show an endoscopic complete response. The CT show no evidence of distant metastasis, and the pelvic MRI.
Yeah. Yes, and pelvic MRI is impressive shrinkage, almost gone. I mean, what we always do is, apart from this morphological MRI images, that's called T2, we always add a diffusion, which is a functional imaging. And if we see there a high signal spot, that would suggest a residual disease, but there is none except for the physiological bowel signal. So it looks like a complete response to me. No signs of the high-risk features around the bowel wall, like the EMVI or the nodes. The EMVI, you can pick up that also after radiotherapy by using diffusion. There are studies that shows that you can pick up a restaging persistent EMVI status. And I don't see that here. So, in fact, complete response.
Okay, thank you so much.
That's a fantastic response to
Yes.
the treatment that's been given, and so I think many people would say that it's not the most difficult decision now. What should happen with that patient?
If I can go back to the first consultation, when we discuss chemoradiation or TNT now with this patient, we are saying we're doing that for the risk of systemic disease, and if it shows a very dramatic good local response, that's an added benefit. But the main goal to give this treatment is systemic. So it's managing expectations. But if this happens, that is fantastic. This opens opportunities. It was a low tumor, yes.
Yes,
So
7 centimeter from the anal
you
verge.
maybe could do a coronal-anal anastomosis, but the coronal-anal anastomosis after chemoradiation gives a lots of complaints. So, yeah, watch and wait is. Of course, you discuss this with the patient because you need follow-up, and yes, we're not sure. 20% of the cases we're missing tumor, and you might still need surgery. But most patients are glad to accept, glad to have been offered this therapy.
Yeah, the patient were enrolled in a watch and wait protocol with a very close follow-up, so every 3 months endoscopy and MRI, and at the most recent follow-up, the complete response persists. So
Good news.
She's a winner.
Yeah.
Congratulations.
Yes.
And no metastasis.
Yeah.
And so it's the oncologist that saved the patient that time round then instead of the surgeon.
And if I had the possibility to use my triplet, I could lower the oxaliplatin and save her from chronic neuropathy.
Yeah.
So
That was easy, but if this was the restaging,
Yeah, that would have been more difficult. That's true. So that is why, from the MR perspective, it's very difficult for radiologists to restage. So especially the fibrotic wall that you see there, they all look the same, but it doesn't necessarily mean that it's a fibrosis with a residual tumor. It could be exactly this similar pattern, having yes or no residual disease. And then diffusion helps very much, but the problem is always if you do a diffusion, you need to have the best protocol. And people try to use gel in the rectal to blow up the rectum so they can look for all abnormalities in the wall, but that doesn't help because diffusion, you're looking for white spots. So white spot versus white gel in the rectum doesn't give the contrast. So don't do that. We only get rid of the air, that's all. And how do we do that? We ask the patient to come in and insert an enema, microenema, and after 15 minutes emptying the rectum, and then you have beautiful diffusion images. So that all a radiologist should know when they are participating in the colorectal team, what is important, what kind of questions. So that is what I would like to urge radiologists, do not just participate, but know what your findings mean for the decision making of the team, because that's very important.
So as the previous case, the decision was quite easy because it looked like a complete response, although we know we still miss tumor in 20%. We started labeling this near complete responders. We used to operate on all of them, and they were still complete responders in there. And now patients have read about this, they have expectations. low tumors, they're saying, "Are you sure there is tumor there, doctor?" I don't know. So our diagnostic tools are still lacking. And even if you have an ulcer, you can have a spot of diffusion there, and
Yeah.
if you wait a little longer, it might disappear. So this is the near complete response, a very ill-defined area, but this is where the patient plays a large role. If the patient says, "I don't want any fussing around, I want you to have it out, I don't want to take any risk, do it." If the patient says, "No, doctor, keep your hands off," then we'll go along with it. Unless something on the right where there's a tumor there. Biopsies at 6 or 8 weeks are not all that helpful. Can be false negative, but also false positive. If you wait a little longer, that might help.
And this is very liberating. We have Mr. Organ Sparing expressing still that this isn't an easy field.
No.
And that, I think that's a very important general lesson. This is not the hallelujah, but it's a possibility for excellent outcome, but it's not a field without minds. So
Yeah, we are moving forward, but we should not move too fast forward. You could do a local excision if you think, but then you run into other troubles too to get a definitive diagnosis.
And how much does their baseline disease play a role in that regard? So you've had someone who could have had intended radiotherapy for a less advanced tumor, who's had a near complete response, and you can have someone who's had a very advanced tumor, who's started biologically a much worse place, that's had a near response. How much of that and how much of the treatment that they've had play a role in how long you would wait, whether you'd take a good biopsy with a local excision of the scar that's left to see if there's anything there, or whether you'd operate on it?
Yeah, I think biology trumps T3, A, B, N2 classifications and size. So some big tumors respond dramatically well. Fewer, but I think that, let's say, the 10% of bigger tumors that have a complete response, in our experience, they do as good with watch and wait than the 40% of smaller tumors who do. It's fewer patients, but so we think actually the radiotherapy is an extremely diagnostic tool too.
yes, prognostic. So in this patient's case, maybe we were lucky by using the standard regimen, a not very powerful intervention, the tumor went away. So that gives us so much valuable information.
Yeah.
Now there are some radiotherapists that are going astray here because they say, wow, we can use radiotherapy and chemo to get tumors. There's no need for surgery. So let's give more radiotherapy. Let's boost. Let's give, and everybody knows if you give 150 gray, the tumor will disappear, but you will have a hole in the rectum and your pelvis. So it's very important not to start to get off this road or get on the wrong interpretation of things. If the tumor shrinks or disappears with the standard treatment, that's most valuable information. That's not a reason to give a double radiotherapy to double the amount of complete response.
So you think with the sinusoid curve, we may be on our way to overshoot a little bit?
Yes,
with giving
and radiotherapists of today, they have forgotten that we tried this 70, 80 years ago, and we hurt the patient so much, so we had tried to bring radiotherapy doses down. To then try and go up again would be like historical ignorance.
So what you think about the holy grail would be if you could tell before you start radiosensitivity, but do we have anything better than size?
I'm not the perfect person to answer. It's also a scientific question, but today we're still lacking far too much stratifying biomarkers. What should we do with this patient and what should we don't do? So we're still too general in our approach. TNM is too far. I advise you all to read NCCN guidelines, how to treat resectable rectal cancer, and then they put T1, T2, T3, T4, any N, it's in the same category. Yeah. And then you can choose any of this. And there's all the different neoadjuvant approaches. And you can consider any of this. And that's not really satisfactory from a scientific aspect.
Yeah.
I think it's a very important point you make as well, Mads. That organ preservation isn't just about preserving an organ, it's preserving an organ that functions.
Yes.
Yeah.
And that should be paramount in the objectives in that patient group, that we have left with something that works as near as possible to how it used to before we started treatment.
Yeah, so we are following them over time, because as we know, radiotherapy, everyone was worried that radiotherapy down the line could, that the organ or the function could deteriorate. So we're now at 5 years. It seems that nothing much deteriorates between 2 and 5. But maybe, I don't know how long the effect can be, but...
Well, the only way to know is to follow your patient for a long time. And sadly, we oncologists don't do that anymore. So...
yeah, we follow them, but the thing is, just with aging, everything worsens too. So, and we don't have a good control group, but we're getting there.
Perfect. Well, I think that's all we've got time for, and I think we've managed to come around quite a lot of difficult topics and the key elements around them in a nice fashion. So I'd like to thank you all for taking the time to be here and sharing your expertise in all these patient groups. And so this, as we said before, is a taster to the webinars that will be coming up shortly. So within the next few months, there will be 3 separate webinars on these different topics, launched by the Colorectal ETC here at ESSO that will be available. And we also hope to use this webinar in a live question and answer session. So if there are other controversies that people want to hear a bit more about, so hopefully we'll be able to make that a possibility. So thank you again for joining.